speaker. This would be my good sir Ish Hendricks. Ishmael is the founder and CEO of NetClinic, pioneering network of smart primary clinics operating across South Africa. He holds a master's degree in executive management from UCT School of Graduates, honors degree in information systems, bachelor's degree in business science from the University of Cape Town, and his career spans sectors including renewable energy, electric distribution, e-commerce, management consulting, and financial services. Really multidisciplinary and very insightful discussion topic.
As I mentioned, my name is Ish Hendricks. I remember I was at the conference about 5 years ago, and I sat at the back, and it's taken me 6 years to get an invite to the front. So, thank you very much for getting me and inviting me to speak. I've gone on a 5-6 year journey now, and I'm beginning to tell the NetClinic story. So today is the first time that I'm actually talking about it in an open platform. So please go gentle on me as I talk about NetClinic. All right. So the title really is, as I lose the slide, there we go. The title is Impacting Township Communities Through Innovation as Practice, right? So I'll demonstrate what I mean by the concept of innovation as practice. Of course, this conference is about tech and innovation, and I'm going to talk about business model innovation. That's what we've done, as NetClinic. All right, so we started in 2019, and this slide represents what we've been through since then, right? So I've scratched out a couple of words, and that's been our journey. Trying things, failing, changing our minds. At the start, we wanted to reimagine healthcare because that was like a big buzzword at the time. We wanted to disrupt the space, and when I put the slide together in the week, I thought, what got us going? And what I realized is that we fell in love with the problem. And in fact, and I looked at it, it wasn't the problem, it was the opportunity of trying to solve the township community challenges. And that's what's driven us, throughout the process. Okay, so we fell in love with the opportunity, from the start. Fast forward to 2025, where we are today. So we own and operate a network of clinics across South Africa. So we play in the occupational healthcare space, the primary care clinic space, and the pharmacy retail clinic space. So we have a network of 15 clinics at the moment. The plan is obviously to expand at this next year in 2026 and double up our network of impact in the communities, right? So currently it's 15 clinics and different types of clinics, although it's one business which is connected to each other. We're the official clinic partner to the ShopRite Checkers Group. There's a long story there, right? But we got that right. And we're also the clinic partner to MediRite, which is the pharmacy, the pharmacy chain, the MediRite group that we're the partner to. And lastly, since we started, we've served over 250,000 patients across our network of clinics, which we're quite proud of. Obviously it all boils down to the impact of the communities. So there's some shots there of our sisters and some of the patients at our clinics in Cape Town, in fact. All right. So the problem that I spoke about earlier on, what I identified back in 2019 or 2018 was the perfect storm, right? So what you saw was a healthcare crisis in South Africa. We all know about that. A highly dysfunctional system, the burden of disease, of course, but at the same time, great health tech in the market, and of course the conversation about NHI picked up at the time. And I saw these four components, and I thought, geez, that's a great problem to get involved in, and that's what we fell in love with, right? So you're all familiar with this, 84% of the population, we're talking about that market, 30% of doctors play in the public healthcare space, a highly inefficient system, and what you're left with is that missing middle of people. So between the public sector and the township doctor, you've got about 10 to 12 million people, which we call the missing middle, that can afford to pay what we charge, which is $390 for a consultation, including medication, that may or may not have medical aid. So that was our market that we focus on. It's that township market, the missing middle, call it the blue-collar worker as well, the ones that are employed. Of course, the quadruple burden of disease, so HIV, AIDS, TB, we see all of these conditions at our clinics every single day, diabetes, and of course, gender-based violence. So that inspired us to solve, to contribute to solving that problem. A great tech landscape out there as well, so very cool stuff. And what excited me the most was medicalized data. The fact that you can go from symptoms to diagnosis to ICD code to medication, and you can code all of that in the primary healthcare, space. I'm not talking about secondary or tertiary care, but just the primary care. There's an example of doing an ear infection with a smartphone, and of course something called Butterfly, which is an ultrasound device which is being rolled out. So you had all this cool tech out there in the market which excited us. Then, of course, the NHI conversation picked up in 2017, 2018. We don't rely on it, but if it does come along, then I'd like to think that we are positioned for it if it does come along in the future. So that was the opportunity that we fell in love with and that we identified back in the day. So based on the problem, we came up with this model. Okay, so I had 4 key components. I called it a hub-spoke and a pod clinic network, managed by a central control center, using a digital platform with different devices, and following the paradigm of value-based care, right, which I think you guys are all familiar with, right? So that was our design, right, having a hub, so a specialized primary healthcare center run by a doctor with specialized equipment, then having the spokes, so it's one level down, a clinic run by a CNP, a clinical nurse practitioner, so a highly qualified nurse, and then at your pods, you've got professional nurses that can also have a big scope of practice. But the intention was to dispense medication throughout the network. So that was one of our principles. And I came up with this great idea to build these pods, as you can see at the bottom there. And I'll tell you a story about the pods in a while. All right, so that was the hub-spoke pod model. The thinking was to, from the pod, you'd be referred to the spoke, and from the spoke to the hub. So you've got your own internal referral network, because one of the big problems in healthcare is referral. And then the data gets lost, and you don't know who you're talking to, and the records get lost as well. The second part was to manage this network with a central control center. So in particular, if you've got 30 nurses across your network, how do you make sure that they're all dispensing 5 Panados for a cough, right? So SOPs are critical, and that needs to be managed by a control center, which we put in place, right? Thirdly, it was technology. So it's quite interesting that there's great health tech out there, but you've got to place it in a context. I think the biggest problem when it comes to health tech is integration. You can't put it into existing systems. And so I thought, let's actually let me build my own ecosystem and build my own tech and do whatever I want within that ecosystem. And that's what we've done from a health tech perspective. Clinical decision support systems, as I mentioned, that everybody's doing the same thing and following the SOPs. And I've got different ways to automate the patient flow in the clinics through process automation. So, at a clinic, we'd have a triage rooms, we'd load up the triage rooms, and the nurses do rounds in the clinic when the auxiliary nurse does the vitals and the makeup of the patient. So that's how we set up the process automation. And then obviously value-based care, going from a fee-for-service model to a performance-based model on a capitation type of level. That was the grand plan. And I spent quite a bit of time studying Michael Porter, and I took out his book as well at the library. I was the first one in about 7 years, but still 5 years later, I still haven't figured this one out. I'm trying to pitch capitation to the medical aid schemes, and it just is not working. So currently we are fee for service, we medical aid switching, but I think I'd love to see how the value-based care thing can actually work, in my setting. But that obviously didn't pan out, and it hasn't yet in our space. So I moved to Cape Town. And I launched the phase 1 of the business. So we spent a lot of time in the communities engaging leaders and ANC councillors and church, everybody. So we were in the community. We screened 15,000 people for free in taxi ranks at ShopRite retail centers. And all of a sudden we built this massive database of like 150,000 people in the community, which we have at the moment, and it's growing. So it was quite a process spending time in the community. I spent 2 years in Khayelitsha. I could tell you every single pothole, all the hijack spots, the corners, which way to go. We really learned and immersed ourselves in the township. And I can tell you some harrowing stories about protection fees and gangsters and being followed at night and all of that. And we went through all of that. And I can stand in front of you as a survivor of all of that. And there was great lessons in that, which we are planning to use now going forward as we expand in Gauteng. Right, so it was real practical innovation as practice, in the actual communities itself. So then we launched our first clinic in Khayelitsha. So that's a shot of the clinic. And I made it quite modern. So you feel like you're in a Sandton clinic or a waterfront clinic. It's upmarket, but you're still paying $390 for a full consult. You're getting a massive basket of medication. But you've got bullets flying outside, and we've had bullets come into the clinic, and we've had stab wounds and trauma and all of that. But I just thought let's make it a great experience for the patients. You've got free Wi-Fi and data and TVs and that type of stuff, in the clinic. And we had a big launch event at the clinic as well, engaging the community. as I reflect on this picture, it was a very well-attended event, and we made quite a splash in the community. But 2 years later, what I actually realized was that we were doing this event not for ourselves or the people, but for all the protection gangs watching us, right? To see, okay, these guys are spending money now, there's something there, I'm going to knock on the door, right? So it's that type of stuff that we learned, and that's a real learning that actually came from that launch event. In Watergate, Mitchell's Plain, we have another clinic off the R300 in Cape Town. So same look and feel, it's whether you go to a Khayelitsha or Watergate, it's the same system, the same team, but again, upmarket type of look and feel. And again, you're paying 390 Rand for a consult, and that was the launch party at Watergate. You can see in the top left there, those are my two daughters. I'm grooming them young so they can take over the business if I survive the year, or they can oversee the liquidation proceedings. Then we built a pod, right? So I built this pod in Johannesburg, and this was a great concept for me. So it's a retail mall clinic. This is inside the Google Letter Square Mall, upstairs from the ShopRite by the Capitec Bank. So it's a self-contained pod. It's in the clinic, so obviously it's convenience, when people walk past. And we did this pod, and it's probably it cost a lot of money to build, and it's probably the worst thing we've ever done, right? It just didn't work. There was water issues, there was no toilet. I never thought about these things beforehand. And we learned that, hang on, this pod concept is not the way to go, right? And obviously my whole model with hub, spoke, and pod were pods, right? So we had to shift there. In fact, the pod is locked up in one of our storage rooms at the moment. We had to disassemble it. It took like 3 months to build. But we had to pivot because it just wasn't working. And so then what I did was I approached Medurite, the pharmacy group, and I got a different version of the pod, which is a retail pharmacy, right? So we've got, we've currently have 5 net clinics inside the Medurite pharmacy. It's run by a nurse or a CNP, and we're expanding now across the rest of the network this year, and there are about 25 more to go as phase 1 with the Medurites. But now all of a sudden I've got a pod network, but with Medurite. Same concept, Medurite to net clinic Khayelitsha, and then obviously to the hub. So that's how we pivoted from the pods to the Medurites. That was the launch of Google Letter, so I'm skipping here, right? So we at the pod launch, and then we've got an outdoor version of the clinic. So this is it's a container type of setup. It's in the ShopRite center outside, and we initially set it up in Nomzamo Strand, close to Macassar. Jean will know where that is. We had the clinic as you come into the ShopRite center, and we built this pod. It cost me 750,000 Rand to build this thing. And it just didn't work. We were seeing 2 people, 3 people, it just did not work. And then my whole pod model went out the window. So I thought, geez, what are we going to do now? And then we moved the pod to Mfuleni, the ShopRite center, right? So we had big trucks and cranes and to move the pod. We found the space after, lots of effort. And now this clinic is our highest performing clinic out of all the clinics that we have. Just simply by moving it somewhere else, right? And it's highly profitable. And Sis Bongiwe and Sipo are seeing about 35, 40 people a day, every single day. So that's a great example of, again, pivoting when something is not working, which we did here. It wasn't the pod, it was the location of the actual outdoor clinic. That was a launch at Mfuleni as well, so a lot of community engagement. And that's an example of our Medurite clinic. So inside the pharmacy itself, they call it Medurite Plus, like a Discam or a Clicks, where you see our net clinic nurse, you get a script and you fulfill it next door at the pharmacy. So it's convenience, and I think we charge, it's 290 Rand for that consult. And we dial the doctor in if required, from a virtual telemedicine perspective, all right? Then we've got these ShopRite, we ShopRite's clinic partner across the supply chain. So at all the distribution centers across South Africa, we've got OC Health clinics. But again, same system, and we look after, I think it's about 15,000 people for the ShopRite group. So it's work medicals, primary care, chronic care, IODs on the floor, etc. Right? So that's a shot of the inside of the clinic. That's the ShopRite Centurion DC. So all the ShopRite and Checkers stock come from this DC, right? And we see about 25 people a day there at the DC, and that's how Riverfield's one. So again, upmarket. It's not a dingy OC Health clinic, at a DC. It looks quite nice in my opinion, right? So all of a sudden, if you remember that hub-spoke pod, we've got these a network of community clinics, Medurite clinics, and DC clinics. And the control center is in the middle, and it manages the network, across the different types of clinics. But the central idea is that the truck driver at the DC, when we look after him there, when he goes home to Khayelitsha, we just continue the care where he lives. And that's the whole point of an integrated hub, spoke, and pod model. And we also solve the referral problem by having it, doing it in-house. So from a services perspective, from acute care all the way to wound care, men's health, STI, HIV management, procedures, etc. That's a snapshot of our full service offering. This menu took us about a year and a half to actually develop. We change it all the time in terms of what we do, and we adapt it to the markets. So general consultations, chronic care, STI treatment. I've got lots of stories about STI treatment at our clinics, and wellness tests. We use Pathcare for our lab tests, women's health, pap smears, implant insertions. So it's quite a full spectrum of healthcare at a very affordable level. We even ventured into the IV bar space, and we came up with our own cocktails. So we call it Net Boost, Net Fuel, and Net Plus. So instead of paying like $2,500 for an IV cocktail, we charge like $350. So we just like disrupt that whole space, and now we're offering IV bar drips to HIV patients in the heart of Khayelitsha, so because we can. And it's not difficult, and it doesn't have to be 2,000 Rand. So that's another example of product innovation that we came up with. So lastly, I just want to talk about a partnership with the Department of Health. So on the left-hand side at the bottom, that's Net Clinic, our Khayelitsha clinic, and on the right-hand side is the public Ubuntu clinic. I don't know if anybody's done any practicals or learnerships at Ubuntu clinic. No one in Cape Town? So it's quite a big clinic. The Ubuntu clinic itself is the HIV clinic for one of the biggest HIV clinics in the Cape region. So they've got about 15,000 HIV positive patients. So because you got partnerships for immunizations where you got government stock and you can charge 150 for immunization, or STI stock, or family planning, but there was no partnership in South Africa for HIV treatment, ARVs, right? So I saw that gap, and I approached the Department of Health in the Western Cape, and they're quite innovative. So I'm not saying you can do the same in Gauteng because it's different challenges here. But, we spent 2 years coming up with the solution. And then what I did was, I don't know if you're all familiar, but they put people in clubs. So, you in club 1, you come on a Monday and you collect your 3 months supply. You come on that other date for your labs, your consults, etc. So I formed Net Club, right? So, the club system. And what we did was we partnered with them, and we have decanted the HIV patients from Ubuntu to Net Club. We house Net Club at our clinic at Site B. And the big question was, who pays for it, right? So the government, I wasn't really getting any cash from the Department of Health. So what I did was I came up with this whole thing where I've shifted the costs to the patients that can afford 650 Rand for the entire year. So 650 includes all your medication, all your lab tests, the consultation, everything. So I gave those patients the choice of either carrying on at Ubuntu Clinic or coming to Net Club and paying something because it's around your schedule. And we did that, and we've recruited 500 people from into the Net Club, and it's a great model. And I solved the problem of like payment, because the patients are very happy to pay 250, 400 Rand, collect their medication for free, and then if they want to, they can have a Net V drip, to boost the immune system at the clinic itself. So that's just an example of another innovation we came up with there as a partnership. And then finally, I just came across this ad last night, never before as a car, and many of us can remember this back in the day. There are always inventions, but few innovations, words, but little wisdom, essays, but few poems, speeches, but little character, songs, but no classics, ads, but no art. Do less, do it better, make it count. And for me, it's about earning the right to scale. I think as a business, we've been through that process now for the past 2 years, and we're certainly taking one step forward to growing our network in 2026.
Fantastic presentation. I was just looking at your website. Beautiful, I must say. I just wanted to ask, in regards to your community clinics, where you charge about $390 consult and script and medication. So, what type of medication are you dispensing? Because if you're running a nurse model, surely there's particular medications you can dispense, and how do you sort of choose that amount of medication? That's just the first question, and then the second question. Maybe answer the first one. Sorry, the second one.
Yeah, it's a good question. So we spent 2 years developing our SOPs. So our model is it's CNP run but doctor supervised. So because all our, everything's on systems based. So Dr. Nabil, for example, sits in at his office and he can oversee what the nurses do in the clinic. But he only gets involved in like 1% of the consults, because the whole model is to task shift down to the nurse. And they've been around for like 30, 40 years in the industry. You can't tell them what to do when it comes to patient care. So, they are the real experts in that space. So what we did was we used Transform. So we order our medication from Transform. But what I did was, I'll order, for example, Bernardo's, not the white one, but the green one, because the community think that the green one is more effective, even though it's the same thing, right? So it's called Painamol. So all these tricks that we did across all our formulary. So we'll buy like 10,000 pill, 10,000 in a box, and we'll decant it into like packets of 5, which is a mission, but that's how we do it. So we give 5 of that, 10 of that, and so economies of scale to buy it, and we distribute across the different clinics. That's how we can afford the 390.
I get you. Last question is more in regards to when you started. Obviously, at the time you're a small guy. Now you're a big guy surviving bullet shots. Just in regards to partnering up with a big organization like ShopRite or their pharmaceutical arm, how do you make sure that they don't get rid of you at some point, and they consistently use you in particular?
Yeah, I mean, if they want to get rid of us, then they must. My job is to make sure that they don't want to do that, because we're just delivering incredible value. It's obviously we've got agreements and contracts in place, but you still got to keep delivering. And I just saw an opportunity, and we pitched a good business model. In fact, what ShopRite, the supply chain, the DC clinics, what they loved is the fact that we could take care of the truck driver at where he lives in Khayelitsha. So a lot of the OC Health players can't do that. They focus only on OC Health, right? That's the check that they refer out. So I just saw a gap in that. I thought, hang on, let's just try to close the loop. And I pitched that. We were very cost effective as well, and that's how we did that, So just trying to be innovative, lean in terms of costs, and that's how we managed to build these partnerships. And just to correct you, we are very small still. We're still a startup. We're still young, and we're still pushing. Every single day it's like a new day, and we just keep going and we try and innovate. And I promise you, if I'm invited next year, if I come back next year, I'll have a totally different business model, and that's the point. That is the point, because the innovation is practice. Like, I'm innovating as I go every single day. That's what we're doing. 70% stays the same, but that 30% you keep sort of adding. And now we're looking at the telemedicine space. As like the next step, and we've got quite a big opportunity in that space. I'm anti-telemedicine, but I've changed my mind because there's a great opportunity, and we're looking at that now, getting that right.
Good afternoon, thank you. I don't have a question, but just a compliment and admiration for what you're doing, and maybe to encourage you to keep on walking, like Johnny Walker says. There is such a need for what you're doing. Primary health care that's run by nurses is the backbone of the public sector, but not in private health care. I think we are now doing that for the private sector, and let's see how the patients vote with their feet. Thank you.
Hi there, Ish. Really great work that you're busy with. It's actually very inspiring. So my question is around, I love the spirit of innovation and disruption that your company is all about. And so I'm wondering about, on this theme of innovation, regarding the rise of mobile technologies for democratizing services that are usually at your tertiary level, trying to democratize and bring it into the primary level for greater access, such as colposcopy services. What is your interest in that? Are you looking at any, emerging technologies that are centering around that? I know of a small research clinic at Site B in Khayelitsha. They are colposcopy-focused research. It's the Khayelitsha Cervical Cancer Screening Clinic. Yeah, so like a player like that, would that be an interesting partner for your business to try and explore how you can work together and bring colposcopy down to the primary level and scale it into the network that you already have established. That is so beautiful to hear about.
Jeez, like that's a difficult question. No, I mean, look, obviously we've got, as NetClinic, we have a scope of practice, right? So, you don't really want to move out of that. Pregnancy scans, for example. So, we do antenatal consults, but to a certain level, I think it's 18 weeks. I can't remember now. But when it comes to the actual, the scanning, we stop them, we refer out. I'll get to your question in a second, because that thing costs 40,000 rand, the machine. Right, so from a business perspective, I've always got to keep things going. My biggest challenge is trying to balance impact and profitability every single day. I mean, that's the key, because nurses are expensive as well, and medication is expensive, rental is expensive, so you always try to balance that. And if I can't do that, then we'll close the business down. So when I'm introducing new technologies and all of that, I always look at it from a cost perspective. How many consults am I going to have to do to break even on that 40,000 rand machine? So the nurses wanted all sorts of stuff, like in the beginning, like Dynamaps. The Dynamap machine that you see at the hospitals. I mean, it's like in the corner there, no one's using it. The blood pressure machine, the manual one, works better than the battery operated one, because the batteries keep running out and they put it in the wrong way. So it's that type of stuff which you actually deal with every single day. So we would definitely look at partnering where we could refer out, but then who pays for that, right? So there's got to be some medical aid contribution. In the public space, I'm not sure in Kalicha if they take medical aid at that place.
Right now it's free because it's research.
Yeah. So there you go. I mean, it's research, so it's funded by somebody. But the minute you try make a business model out of that, you're just not you won't be able to do it. So I think there's enough in terms of our scope of services, which is quite big, to solve a small chunk of the bigger problem. So, we just focus our lane, focus on what we do, and that's how we do it. Yeah.
Hi. I don't know if I heard you right, but with regards to the Net Club, I think you said you joined the Ubuntu clinic, and then you sort of took some patients from there, and then you formed the Net Club from their other clubs. So my interest is, from how you explained it, the Ubuntu clinic is a government clinic. Did I hear you right when you said then the Net Club members pay 650 throughout the year or something like that? I asked this from an ARV manufacturer's perspective that supplies government. Are you taking drugs from there and then selling it on the side, or is it it actually got me very worried?
No, that's a good idea. Maybe I should do that. No. So what we do is the partnership is that Ubuntu supply the ARVs, the 3-month supply, and they do the actual lab test itself. The NH, what is the NH National Lab? So they do it there. So the patient's paying for the consultation with Sister Viv, who's an HIV expert at Site B. So I think it's 250 for the lab test. So she'll draw the bloods, it'll go through, the result will come back, and she'll have a personal consultation to discuss the viral load and what's happening with the patient. So they pay 250 for that, and then 450 would be the full consultation, which is required every year. And patients are happy to pay for that. If they want to stay at Ubuntu, that's fine, because some people can't afford that. But those that are employed, that earn, are happy to join us and have a more private experience when it comes to ARVs.
Okay, thank you. So they pay for the consultation, not for the actual drug?
Correct.
Okay,
the drugs are free, like immunization and STI and family planning. It's part of that partnership that we did there. Right. And just, in fact, we're rolling it out to Mfuleni now. So because it's worked, so we're going to try it at Mfuleni. And I'd love to see if I can get it right in